Hello and welcome to the SENSE webinar on the Accessible Information Standard SCCI1605. I'll just start with some housekeeping. So firstly, everyone except me is muted for the webinar and will be muted for the duration of the webinar. If you have any technical issues during the webinar which you think are at our end, please let us know via the question box on the right-hand side of your screen in the control panel. If you want to hide the control panel, then you can click on the red arrow at the top right-hand side of your screen and click on it again to display the panel again. If you've got questions at any point during the webinar, you can type a question into the box on the control panel. I will answer as many questions as I can at the end, but there are over 100 people registered for the webinar today, so I'm unlikely to be able to answer everybody's questions. What I would say is that I will come back to you. You can also email me with questions after the webinar. My email will be on the last slide. Okay. I'll share the PowerPoint after the webinar and you can view a recording of the webinar and access fact sheets via the SENSE website if you Google SENSE and Accessible Information Standard. Okay, so I'd like to start by looking at what we will cover today. We'll start by introducing the standard and its aims, who it applies to, and the intended beneficiaries. We'll look at the rationale for the standard, the content of the standard, including the implementation requirements, and we'll briefly look at enforcement of the standard towards the end. We'll close by looking at some examples to test your knowledge and to see whether I've done my job properly. So we've got quite a lot to get through, so without further ado, what does SCCI1605 do? In summary, the standard describes the steps that health and care providers must take to ensure that people who use services, their carers and supporters can access information and are supported to communicate. So to emphasise, this standard is aimed at ensuring that individuals can access information and communication support. And to do that, organisations are required to take 5 key steps. These are firstly, to identify people's needs and to take a proactive approach to identification. Secondly, to record people's needs so that those needs, once identified, are not forgotten. Thirdly, to flag needs on records so that needs are not overlooked. 4, to share information about needs with other providers so that the onus doesn't fall on the individual to make sure people know about their needs. And 5thly, to meet needs. So that's identifying, recording, flagging, sharing and meeting needs. And I'll come on to that in more detail later. The information standard has the same legal force as government guidance. It was issued under the Health and Social Care Act 2012. Before the standard was issued, there was a question over whether the standard would be mandatory. However, it's now absolutely clear the standard is compulsory and health and social care providers must follow it. So to give you a little bit of background and history, the standard was effectively born out of a judicial review proceeding. Campaigners associated with RNIB brought judicial review proceedings against the NHS for failing to provide confidential medical information in an accessible format. Campaigners were angry that they were effectively forced to share their confidential medical information with others, as they couldn't access it without support. And I think it's fair to say that there's some very emotive language around this accessible information issue. So, for example, campaigners talked about information segregation and information apartheid. So the judicial review proceedings were suspended because the Secretary of State for Health agreed to produce the Accessible Information Standard. And the standard was approximately 2 years in the making. and is the result of significant collaboration between stakeholders, including third sector organisations and disabled people. There is a lot of support for the standard amongst the third sector, and I think that's really worth knowing for providers for compliance purposes. And I think that failure to comply with the standard is likely to attract quite a lot of negative publicity as a result. The language used in the standard is that typically contained in government guidance. So if the standard uses a must, then the organisation must do it. If it's a should, the organisation should do it unless a legally sound reason not to exists. If the standard uses a may, then the action is optional and there is no legal duty to carry out the action. However, it usually implies that there is a power to do something and the organisation is not prohibited from carrying out the action in question. The standard tells organisations how they should make sure that individuals can access and understand the information they are given, and how to make sure that individuals get the communication support that they need. The standard is of particular relevance to individuals who have sensory loss, including people who are blind, deaf with a small d or a capital D, or deaf-blind, and people who have a learning disability. However, it will also support people who have other communication disabilities, such as aphasia, autism, or mental health conditions which affect their ability to communicate. The standard says that individuals with any form or type of disability or impairment which affects their ability to read or receive information, to understand information, and or to communicate are within the scope of the standard. So note that this is about communication needs which relate to a disability, not communication needs which relate to foreign language needs, and I'll come on to the justification for that in more detail shortly. What you need to know for now is that the overarching aim of the standard is to prevent people with communication needs associated with a disability, impairment or sensory loss from being put at a substantial disadvantage in comparison with persons who are not disabled. And that aim echoes provisions from the Equality Act. Guidance produced by the Equality and Human Rights Commission states that anything which is more than minor or trivial is a substantial disadvantage. So if the standard is implemented properly, individuals should be able to make decisions about their health and well-being and about their care and treatment, self-manage conditions, access services appropriately and independently, and make choices about treatments and procedures, including the provision or withholding of consent. SCCI1605, as I've already outlined, was published under Section 250 of the Health and Social Care Act 2012, but I think it's fair to say that there is a much wider legal context to the information standard. The Equality Act 2010 is really the primary legal framework for the Accessible Information Standard. And the Act places a legal duty on all service providers to take steps to make reasonable adjustments in order to avoid putting a disabled person at a substantial disadvantage when compared to a person who is not disabled. The Act is explicit in including the provision of information in an accessible format as a reasonable step to be made. The Care Act 2014 details specific duties for local authorities with regards to the provision of advice and information. And this includes the requirement that information and advice provided must be accessible to and proportionate to the needs of those for whom it is being provided. There's also a duty to provide reasonable adjustments to enable people to access the assessment and care planning processes. In relation to codes of practice, many professional organisations involved in the provision of health and social care have similar commitments as part of their codes of practice. The information standard is really the first attempt to consolidate and expand on various existing duties. I'd just like to reflect a moment on the moral and ethical context of the standard. Despite the existence of legislation and the guidance outlined on the previous slide, in reality, many people using services continue to receive information from health and social care organisations in formats which they are unable to understand, and they do not receive the support that they need to communicate. I've frequently got clients reporting to me that they have missed appointments or not understood vital information because information has not been provided in an accessible format, or because interpreters have not been provided. People have had to muddle through using family members as interpreters. And it's also extremely frustrating when communication information is not passed between departments in local authorities or in the NHS. I was working with a local authority that met with a deaf-blind woman with Usher syndrome who was about to have a baby. She's a BSL user and she has an extremely reduced visual frame or tunnel vision. So if you imagine that you are looking through a tube, that's what her sight is like. But she also has patches within the middle of the tube as well. So she requires a very specialised type of BSL interpreter. And if she doesn't get it, then unfortunately she doesn't understand the BSL interpreter. So despite repeated requests for adequate communication support, the right support wasn't put in place. The BSL interpreters who were booked were not qualified to work with people with a reduced visual frame, and as a result my client didn't understand the questions she was being asked, and the resulting social care assessment was extremely poor. When my team stepped in, we found that the local authority couldn't understand why the woman had not answered questions properly and why the relationship between the social worker and the client had completely broken down. And I think it's, that illustrates really how frustrating the situation can be for our client group, and particularly in an age when data sharing is in theory so easy. And I think that was summed up quite well in a quote from one of my clients. She said to me, "How is it that Sainsbury's have my address and telephone number, know that I bought a bottle of Coke from them back in 2010, and to a large degree managed to meet my communication needs, and yet my health and social care providers still send me letters that I can't read?" The dangers of the failures around the identification, recording, flagging and sharing of individuals' information and communication support is highlighted within the standard itself. So the standard mentions specifically the final report of the confidential inquiry into premature deaths of people with learning disabilities, and that was published in 2013 and found that the lack of reasonable adjustments to facilitate healthcare of people with learning disabilities was a contributory factor in a number of deaths. It also mentions the 2013 Access All Areas report, which was published by Action on Hearing Loss and showed that 28% of people with hearing loss had left their GP unclear about a diagnosis. 19% had been unclear about their medication, and 14% of people with hearing loss had missed an appointment due to not hearing their name being called in the waiting room. Those are pretty staggering statistics. A separate research piece carried out by Sign Health entitled "Sick of It" was published in 2014, and that found that British Sign Language users had worse health outcomes than the general population, and estimated that misdiagnosis and poor treatment of BSL users was costing the NHS £30 million per year. So it's really hoped that organisations will recognise the significant benefits to their patients and people using their services of implementing the standard. And I congratulate you for attending the webinar today in that spirit. Really, acceptance that compliance is in line with commitments to equitable, high quality, accessible and personalised care is an important message. The standard should make a great impact to the outcomes and experience of patients, as well as improving patient safety and clinical effectiveness. And I suppose if you put that another way, organisations that do not implement the standard are at risk of failing to effectively provide healthcare and social care to individuals with information and or communication needs, and potentially denying them the rights to confidentiality and independence when accessing health and social care. So who has to comply with the standard? These are the groups that are covered. And generally, the standard applies to health and social care providers and organisations who are providing publicly funded care or treatment. So you should note that the standard does not apply to private providers providing private health care. However, it does include private providers who are providing publicly funded health care or social care. So that might include dentists providing an NHS service, private companies offering NHS screening services, pharmacy services, private companies providing social care or carrying out commissioned assessments, and it does include providers from the voluntary sector. So this has obviously had an implication for SENS, and we've had to ensure that our house is in order too. Interestingly, the standard also applies to suppliers of IT systems, software and hardware to health and adult social care organisations and providers. And I think that that's quite clever because it will in theory ensure that organisations don't mistakenly purchase IT systems which will lead to them failing to comply with the standard. What about commissioners? Commissioners are exempt from implementing the standard themselves, and that's because they don't generally have direct contact with individuals accessing health and social care services. However, commissioners are not off the hook. They must ensure that their actions encourage, enable and support organisations to implement and comply with the standard. So what does that mean? Well, commissioners should look at their contracting and performance management arrangements, including, for example, incentivisation and penalisation, to ensure that their frameworks enable and support provider organisations from whom they commission services to implement and comply with the standard. So, for example, if a local authority is commissioning for the provision of a day service for older people, the local authority might want to consider firstly looking at compliance with the standard at the tender stage, by asking how providers would seek to comply with the standard. Then they might want to include compliance with the standard as a clause in a contract once a provider has been chosen. And then once the provider has started to provide the service, part of the checking up on the provider should include looking at compliance with the standard. So let's look at a few application examples. This is Noah. He receives private healthcare through his employer from Healthy Life Limited. Noah requires letters in font size 32. When Healthy Life Limited send a letter in font size 12, the standard does not apply, and that's because Healthy Life Limited are a private provider providing a private service. If we look at this second example, this is Sunny and her granddaughter. PHO are a private company and they contact Sunny about an NHS breast screening service. They send the invitation to the screening in 10-point. Their records show she needs 24-point bold, and that falls within scope. So PHO is a private provider, but because they're contacting Sunny regarding a public service, they do have to comply with the standard. So moving on to the standard's beneficiaries, who are they? The standard says that individuals with any form or type of disability or impairment which affects their ability to read or receive information, to understand information and or to communicate are within the scope of this standard. So we know that the standard applies to disabled people and individuals with an impairment or sensory loss. But what's meant by individual? Well, individual is defined in the standard as a patient or service user or the parent or carer of a patient or service user who has communication or who has information or communication support needs. And those needs must relate to a disability, impairment or sensory loss. I just want to reiterate here that the standards beneficiaries are not just patients and people who use services. Parents and carers are within the scope of the standard. And there is some concern that this group will be overlooked. So one of my clients, this scenario actually happened to. So my client is a BSL user. Her daughter can use BSL, but she isn't hearing impaired. She was in hospital and needed an operation, and the hospital didn't commission an interpreter, and so my client's daughter had to interpret for her mum to tell her about the fact that she needed an operation. And I think that that really clearly demonstrates why it's so important that this group are covered by the standard. So let's look at who is covered by the standard in a bit more detail. There are a few notable exclusions that I want to draw your attention to. So remember that the standard is aimed at protecting and supporting people whose communication and access to information needs are related to a disability, impairment or sensory loss. So where an individual has a preference for being communicated with in a particular way, which does not relate to disability, impairment or sensory loss, this is out of scope. So for example, a preference for communication via email, but an ability to read and understand a standard print letter would mean that the provider, the health or social care provider, would be entirely justified to use a standard print letter if that's what they wanted to do. Really important to note that foreign language needs or provision of information in foreign languages is out of scope of the standard. So people who require information in a non-English language for reasons other than disability are not covered by the standard. It's worth noting that organisations may record that information alongside information relating to disability, impairment or sensory loss. So there is a power to do that. The rationale for the standard not applying to foreign language requirements is twofold. Firstly, the Equality Act only requires organisations to make reasonable adjustments in relation to disabilities. And secondly, due to huge national, regional and local variations in the numbers of people needing foreign language interpretation or translation, the level of burden placed by any national framework would vary substantially between different organisations depending on their geographical location. Individuals who may have difficulty in reading or understanding information due to low literacy or a learning difficulty, such as dyslexia, as distinct from a learning disability, fall out of scope of the standard. So again, this relates to the requirements under the Equality Act, and a definition of learning disability can be found in the standards glossary. You can also look at the Special Educational Needs and Disability Code of Practice for more information about learning difficulties. So if we look at this example, Sandeep's daughter falls ill. Sandeep speaks Punjabi and requires a foreign language interpreter so that he can understand what's happening. The hospital refused to provide an interpreter for Sandeep, and they only provide communication support to patients. And the hospital asked Anina to interpret for Sandeep. Now, obviously, I by no means want to belittle that situation, but it falls out of scope. Foreign language needs are not covered by the standard. So this is about individuals, their parents or carers who are accessing health or social care services. The needs or preferences of staff, employees or contractors of the organisation, except where they are always also patients or service users, or the carer or parent of a patient or service user, are not covered by the standard. So let's look at a few more examples. Mary is a nurse and works for the NHS. She needs to communicate with Dave, who is deaf-blind. Dave is the patient. The NHS does not provide a BSL interpreter so that Mary can communicate with Dave. That falls within scope. The NHS have not complied with the standard. In this next example, Mary is the person who is the nurse. Mary is the person with the communication needs. She's deaf and a BSL user. She needs to communicate with Dave, who is a patient, and the NHS do not provide an interpreter. Again, by no means do I want to belittle this situation, but it falls out of scope of the standard. If we take the example a little bit further, however, so let's say Mary's eyesight starts to deteriorate, she needs a social care assessment, then the social care provider must comply with the standard in relation to Mary. So once she is a patient or a person using services herself, then she starts to qualify under the standard. In this example, Edna is dyslexic and she's asked the GP surgery to call her rather than send letters, as she has poor literacy and it takes her a really long time to understand the content of the letters and sometimes get confused. The GP surgery refuse, it's against their policy. This falls out of scope of the standard. There's been no breach of the information standard here, and that is because dyslexia and low literacy are differentiated from learning disability. So remember to focus on disability, impairment, or sensory loss. So there's one more comment that I want to make at this stage about application. The standard is about access to information and communication. Implementation of the Equality Act 2010 more widely is out of scope. So those sections that do not relate to the provision of information or communication support fall outside of scope of the standard. So that exclusion would apply to other forms of support which might be needed by an individual due to disability, impairment or sensory loss. For example, ramps or accommodation of an assistant dog, signage within a provider's property. So looking at the next example here, this example falls out of scope. There may well have been a breach of the Equality Act, but that is not covered by the standard. So let's look at the content of the standard. The Accessible Information Standard directs and defines a specific, consistent approach to identifying, recording, flagging, sharing and meeting individuals' information and communication support needs by NHS and adult social care service providers. So what is meant by each of these steps? Well, we're going to look in more detail on the next few slides. The health and social care providers must identify the communication and information needs of those who use their service. Identification and recording of communication and information needs must happen at first contact with the service, or for existing patients or people using services at the next possible contact or at review. So it's not enough to say, well, the individual didn't say what they needed. There is a duty on professionals and relevant staff. They should proactively prompt individuals to identify that they have information and or communication needs and support them to describe the type of alternative format or support that they need at their first or next interaction with the service. There's a requirement to record the communication and information needs which have been identified clearly and consistently on the individual's record. And again, this must happen at an individual's first or next contact with the service. Now, note here that the requirement is about recording needs, not why an individual has those needs. So the record should say that a person requires a BSL interpreter, not that a person is deaf. So why is that? Well, making a note of someone's impairments will not always tell you what their communication needs are. And I think looking at somebody who is deaf-blind is really works to illustrate that. So someone who is deaf-blind could communicate in a range of ways. They could use BSL, they could use hands-on BSL, sign-supported English, deaf-blind manual, Tadoma, lip reading, clear speech, and I could go on. So providers have to record the communication and information needs. Now, providers may record both the reason for and what is actually needed. So it's a power to do that. It's also worth noting that a recording of an individual's information or communication support needs must be highly visible to relevant staff and professionals. In the context of this standard, highly visible means obvious and overtly apparent, visible on the cover, title and/or front page of a document, file or electronic record, visible on every page of an electronic record, for example as an alert, a flag or a banner, and highlighted in some way on a paper record so as to draw attention to the information as being of particular importance. So, for example, you might use large or bold font or a different colour. The record must be detailed, so the specific type of alternative format or communication support which is needed or required needs to be detailed. So it's not enough to say large print, you need to say what size font. The standard gives very specific details around how the data should be recorded. And this information can be provided by request, but it's there in the standard. Note that for health there are standardised codes and read codes which will be included in the patient management system which must be used. So in electronic systems which use SNOMED CT, READ V2 or CTV3 codes, information must be recorded using the coded data items associated with the subsets defined by the standard. In electronic systems which use other coding systems or terminologies or where paper records are used, information must be recorded in line with the human readable definitions or categories associated with the data items. Organisations must ensure that information recorded about individuals' information and communication needs is accurate. So there must be systems in place for edit checking and quality assurance and making sure that data is kept up to date. And that within the standard, that is a should. So systems for edit checking, quality assurance of data should be put in place. Data must be current. So organisations must ensure that data recorded about individuals' information and communication support needs is current. And systems must enable records made about individuals' information and communication support needs to be revised and should include prompts for review at appropriate points. Where an individual's got a care plan, the organisation responsible for developing or holding the plan must ensure that it includes information about the individual's information or communication and/or communication support needs recorded in line with the standard. Recording of demographic data or protected characteristic strand affiliation. Now, if an organisation fails to record that a person is deaf or deaf-blind, if providing the communication and accessible information needs have been recorded, then that's not a problem. So there's no requirement in the standard of recording of information or communication requirements for statistical analysis or central reporting. So this standard is about delivery to the individual. It's worth noting that there is guidance that applies to that situation of recording for statistical purposes, but that this scenario is not covered by the standard. Organisations must have a consistent flagging system so that it is immediately apparent to anyone accessing the individual's record that they've access to information or communication needs, so that they're prompted to take the appropriate action needed, and so that there's a trigger for auto-generation of information in an accessible format. The guidance documents published along with the standard advises on how flagging systems should be implemented on electronic and paper-based systems. So this next point is really important. There's a requirement to share the identified information and communication needs of the individual with other professionals at key points of care. So if there's a referral to another service, or if somebody's discharged, or if there's a handover, then communication and support needs do need to be shared. So GPs making a referral to a specialist must share information, social care departments making a referral to a provider organisation for provision or for an assessment must provide information. Organisations must ensure that information about individuals' information and or communication support needs is included as part of existing data sharing processes and as a routine part of referral, discharge and handover. All information sharing should follow existing processes and information governance protocols. So it's worth noting that the dovetailing of the requirements around the flagging systems with the data sharing mean that an illegible scribble on page 6 of an assessment sent to a provider as a referral telling us that Billy needs a BSL interpreter in font size 24 will not meet requirements of the standard. So lastly, there is a duty in the standard to meet the communication and information needs identified by providing accessible information and or communication support. And this is broken down over the next few slides. If an individual has information or communication needs, then all information provided to them, including personal or direct communication, so for example appointment letters or prescriptions, care plans, assessment reports, as well as generic or indirect communications such as leaflets or manuals or surveys, must comply with the standards. That's both types of communication, personal and direct, or generic and indirect. Organisations must ensure that electronic patient or service user administration and record systems automatically identify a recorded need. So organisations must ensure that a standard print letter is not sent to an individual for whom this is not an appropriate or accessible format. So it's not okay just to say, computer said no. This will be a game changer for our client group, but should also help local authorities and health authorities. So to give you an example, I've recently had a local authority contact one of my clients who is deafblind. They contacted her by letter to request an audit of her direct payment activity. It took her over a month to respond to the letter because her com guide only comes for 2 hours every fortnight, and that's the only time she can access letters. And those hours have to be used for other things as well, so she ran out of time in the first session. And obviously that's, it's not great for the local authority either. As this slide shows, people's communication support needs can be extremely diverse, and it's obviously critical that organisations get it exactly right. So I gave you the example earlier with the deafblind client with the reduced visual frame. To give you another example, I have a colleague who communicates using deafblind manual, and the number of times a BSL interpreter has turned up to a hospital appointment would be absolutely farcical if it weren't so dangerous and disempowering. Colleagues, including myself, had to attend the hospital so that the colleague could understand what was happening. And looking back at the anger I described at the injustice campaigners felt about the failure of providers to meet needs, I think that this example demonstrates exactly why there was so much anger. Imagine being forced to tell your work colleagues about your health conditions. The standard says organisations must ensure that patients, service users, carers and parents are provided with appropriate communication support, including using aids or equipment and or by staff making adjustments to their behaviour to enable effective communication. So you need to know about and be able to work with different communication tools and techniques. You don't need to provide certain equipment, so for example you don't need to provide hearing aids, but you do need to provide a hearing loop so that hearing aids can be used effectively. If someone's deaf on the right side but hears well on the left, then you need to know that you need to position yourself on the left side to be able to communicate with that individual. You need to be able to use clear speech and know that if someone is lip reading, then covering the mouth or eating during an appointment is going to impede communication. You need to know about unusual communication methods. So, for example, have you heard of Tadoma? Tadoma involves a deafblind person placing their thumb on the speaker's lips and spreading their remaining fingers along the speaker's face and neck. And communication is transmitted through jaw movement, vibration and facial expressions of the speaker. So it's fair to say that some training may need to be put in place for staff to ensure that they're able to comply with this part of the standard. So there's a few things that you need to know about meeting needs for communication support. Firstly, communication support which is needed by or provided to a patient or service user as part of an agreed mental health care plan or other mental health pathway of care, and which may be termed therapeutic in nature, is outside of the scope of the standard. So if we look at this example above, Fred is blind, he's also agoraphobic, and appointments and meetings make him extremely anxious. His mental health plan stipulates that for therapeutic reasons, all communication is via a one-to-one support worker. And in a way, this is a trick question, so this is out of scope. The support falls out of scope, so it's important, obviously, but it's not covered by the standard. Organisations must ensure that communication professionals, including British Sign Language interpreters and deafblind manual interpreters used in health and social care settings, have appropriate qualifications and disclosure and barring service clearance, and that they're signed up to a relevant professional code of conduct. And you also must obviously ensure that the right interpreter is booked, and I suppose that my previous example of the reduced visual frame demonstrated that. People with communication needs may need longer appointments, and that might be because interpretation takes longer, so and in the case of deafblind manual, much longer, or it might be because the individual needs more time to understand because of their learning disability, and that falls within scope of the standard. In relation to advocates, if the advocate is there to support communication and understanding, then it's covered by the standard. But matters of consent and capacity, which are not related to informational communication support, fall outside of scope. So decision-making support under the Mental Capacity Act 2005 is out of scope. The standard distinguishes between support to communicate, which is in scope, and support to make decisions, which is out of scope. So if, for example, we compare the two examples, so example A, a congenitally deafblind person lacks capacity to understand social care assessment processes or make decisions about social care provision. If the individual can communicate likes and dislikes but needs an advocate for decision making, that would fall outside of scope. If we contrast that to a second example where a deafblind person with acquired deafblindness has capacity to understand social care assessment processes. The individual uses deafblind manual for receptive communication, but can speak. However, due to a severe speech impediment, the person also has difficulty communicating views, wishes or views. In that example, the deafblind person may require an advocate for communication purposes in face-to-face meetings. So somebody such as a spouse who might be able to understand the speech impediment may be able to support their communication. In this example, Joseph requires a palantypist to receive information in face-to-face appointments. If the GP surgery refuse to provide a palantypist because they're too expensive, and refuses to allow longer appointments because they need to consider the needs of the patient, this falls within scope. The surgery have not complied with the standard. If we were to take that one step further, however, let's say Joseph could lip read and use clear speech, but he had a preference for a palantypist. In that instance, there would not be a duty to provide a palantypist because it wouldn't really be a reasonable adjustment because they're so expensive. Organisations must prepare and publish or display an accessible communications policy or similar, and that should outline how they will identify, record, flag, share and meet the information and communication needs of patients. And quality assurance must be undertaken by organisations, and you must encourage service users and patients to provide feedback, for example through service user groups. So some exclusions: corporate communications which are produced or published by organisations which don't relate to direct patient or service user care or services such as annual reports, accounts, strategy and policy documents do not fall within scope of the standard. It is worth noting, however, that the Equality Act would still apply, so if somebody were to request a copy of the annual report in an accessible format, then it may still be considered a reasonable adjustment to provide it. Expected standards of general health and social care communication or information fall outside of scope. So this isn't about general accuracy of information. Just a note about websites. The standard remains relevant in circumstances where a health or social care professional would usually refer a patient or service user or their carer or parent to a website for information. In those instances, it would be the duty of the professional or their employing organisation to verify that the website is accessible, and if not, to provide or make the information available in another way. So an example might be if a GP would usually direct a newly diagnosed patient to information on the practice's website on how to manage their condition, then he or she would need to check with the patient that they're able to use the website for that purpose. If the website is inaccessible to them, then the GP would need to provide the information in an alternative format. The same would apply, for example, if a process of care planning is to refer people who use services to the website for more information. So just taking a look at this example, Sally's only receptive means of communication is deafblind manual. Sally's social worker directs Sally to the website to find out more information about social care provision prior to her care planning meeting, and that's sort of standard practice for the social worker. When Sally explains to her social worker that she's unable to access the information online, her social worker sends leaflets to her parents so they can tell Sally about what is available. If Sally wants to be able to access that herself, that is not good enough. The social worker would have to arrange for a face-to-face meeting with a deafblind manual interpreter to provide the information in deafblind manual so that Sally receives the information herself. The standard gives an example of a GP surgery. So again, if a GP standard practice is to refer patients who are newly diagnosed with diabetes to the website for information about managing the health condition, then the GP surgery must ensure that the website is accessible. And for people who are unable to access the website, then the GP must meet needs in another way. So just looking at implementation timescales, organisations must effectively prepare for implementation of the standard. You should already be identifying and recording information and communication needs, and all 5 stages of the standard must be implemented by the end of July of this year. So organisations must assess their current systems and processes, develop and roll out a local implementation plan, and they must update or replace current systems if they don't comply with the standard. There must be a review of the ability of the workforce to implement the standard, and there should be training and awareness programs put in place so that compliance is achieved by the end of July. Clinical leads and adult social services team leaders and service managers should review the implementation guidance accompanying the standard and consider whether changes are required to current practice. NHS England have commissioned a variety of activities and resources to support implementation. There's a wide range of implementation resources available on the NHS England website, including a checklist prepared by Healthwatch and a contact card for collecting communication needs data. There's also, I've just been contacted by Bradford to let me know that there's very soon going to be information from them about first contact teams and ensuring that first contact teams are set up to comply with the standard. And remember, if you've not already done so, you can register an interest to receive free consultancy from Sense, and you can do that by emailing me directly. Not everyone will qualify, as the NHS have paid for 5 days of our time, but obviously if you don't register, then you won't qualify. So compliance with the standard is a legal duty. Organisations that do not comply with the standard would be leaving themselves open to legal challenge. Related to this, non-compliant organisations should also be aware of the risk of complaints, investigation and negative media coverage. I've already touched on the fact that there is significant interest in and support for the standard from a range of voluntary sector organisations who will continue to actively support and push for implementation of the standard locally as well as nationally. Complaints would be via the usual NHS or adult social care complaints process with recourse to the Ombudsman, and that's the Parliamentary and Health Service Ombudsman and the Local Government Ombudsman. Whilst there is no requirement for organisations to report on their adherence to the standard and no national audit or data set being created, the standard does include requirements for organisations to publish or display an accessible communications policy, and that should explain how they will follow the Accessible Information Standard and an accessible complaints policy. The inclusion of these requirements is intended to support ease of compliance and assessment by interested organisations, and also to ensure that people with information and communication support needs are able to provide feedback to organisations about their experiences. Commissioners play an indirect role in enforcement, so the specification, as I said, does make clear that commissioners must support providers to comply with the standard, including through contracts, tariffs, frameworks and performance management arrangements. The Care Quality Commission is the independent health and adult social care regulator. It monitors, inspects and regulates health and care services to ensure that they meet standards of quality and safety. The Care Quality Commission have stated that they will look at evidence of how services implement the Accessible Information Standard when we make judgments about whether services are responsive to people's needs. Health Watch is the health and social care consumer watchdog, and they will also have an impact on compliance. Health Watch has statutory powers to enter and inspect services and should be reporting on trends and themes. There's a regional Health Watch in areas around England, and there's also a national Health Watch. A review of implementation of the standard was scheduled for September, and it's looking like that review will now be pushed back to January, and that's to allow ample time for proper evaluation and monitoring of implementation to take place. So we're going to test your knowledge. The scenarios which are going to come up on your screen are going to be there for you to read. The voting buttons should pop up on your screen after you've had the opportunity to read the scenario on the slide. So providing our technology works, you should then be able to click on the yes button or the no button in response to the question that pops up. Okay, so I'm not going to read out everything that's on the slide, I'll just leave you ample opportunity to read it. Okay, so your voting button should be about to come up now. So you can see that the question here is, have the commissioners complied with the standard? So you can either click on the yes button or the no button. Okay, so the answer to this is no. The commissioners haven't complied with the standard. The contract fails to mention the information standard requirements. It doesn't penalise the provider, and the contract is renewed. So those frameworks don't encourage compliance. It's also worth noting that the provider possibly failed to properly identify, record, flag or meet needs. So moving on to the next slide here, you should be able to see Sundip. I'll leave you to read that slide. Okay, so just popping up now, has the social worker complied with the standard? Okay, so no, the social worker hasn't complied. The local authority should identify, record, flag and meet Sundip's communication needs. So the social worker's communication needs are a red herring here. The social worker's communication needs, remember, as an employer, that needs to be met by access to work. Okay, so just moving on to the next slide. So Polly has just been diagnosed with diabetes, and I'll let you skim through that one. Okay, so the question here is, has the surgery complied with the standard?
Great, I think we're starting to get it. So no, I can see that 93% of you can see that no, the GP surgery hasn't complied. There's no flagging system. The surgery should have reviewed and checked the accuracy of the records. And the surgery needs to provide an alternative to the website because it's standard practice to use the website to meet information needs around treatment and managing the condition. Okay, so before I respond to some of your questions, reading all of the supporting documents is one of the implementation requirements. You'll find these on the NHS England website. If you Google NHS England and Accessible Information Standard, then the page will pop up, but the link is here in any event. If you have any burning questions about the standard, then please do feel free to email or phone me. If you've not already done so, then you can register an interest in the consultancy by dropping me an email. Okay, so I've got a couple of minutes, I think. Well, I'm going to run over slightly. I've got a couple of questions. Somebody's asking if I have to have every document available in every format to meet the standard. So really, no, lots of people worry that they need to have 300 copies of Braille information leaflets sat in a cupboard somewhere. That's not the case. Obviously, there's an enormous associated cost with that. This is about making sure that people are not at a disadvantage. So what you need to know is how you will get hold of a Braille information leaflet if one is requested in a timely way. If you are sending information leaflets out to all of your patients, then that's different. Then if you've got 3 people who require Braille on your system, then obviously you're going to need to order 3 Braille information leaflets to send out. Somebody's asking, do we have to contact everyone in our patient records and identify who has a hearing or sight loss? No. Remember that it's about the next point of contact or a review. So the next time that that person comes in, you need to make sure that you are asking them about their access to information and communication needs. I've had several questions relating to whether providers have to pay for interpreters, and several people are raising concerns around costs. Well, I suppose in reality, that legal duty to provide an interpreter did exist before the standard existed. So this isn't new, but yes, that is what the duty is. So you're right to raise concerns about cost, but what I would say to you is that there are certain online interpreter services. You might want to look into these. So they've been designed specifically with medical appointments in mind, and they're a lot less costly than booking interpreters in other ways. But just a word of warning there, make sure that this sort of interpreter is going to work for the patient or person using the services. So if the person needs hands-on VSL or deafblind manual, then this is not the right service. Okay, I'm going to draw to a close. Thank you for attending the webinar. As I say, drop me a line if you've got any questions or concerns. And any questions that have come through today that I haven't had the chance to get to, I will email out about. I will also send a
copy of the PowerPoint out to you by email. Okay, so thank you very much.